It's The Journey with drug and alcohol attorney Mark G. Astor.
All right, everybody, welcome to another edition of The Journey Live, Friday at 5 o'clock. I'm very excited to have a special guest, Dr. Ruth Swissa. And what's really interesting about Dr. Ruth is she's actually from my neck of the woods, which means you probably won't understand either one of us. Or actually, you sound more English than me, so maybe they won't understand me, but they'll understand you.
Maybe.
But either way, I'm really glad you came on the show, and thank you for coming on.
Oh, you're welcome.
So, what's really cool about, I'm going to call you Ruth because we had this whole thing beforehand, not to call you Dr. Ruth because then people get they get crazy with the whole Dr. Ruth thing, so we're going to leave it. And I always thought of you, I always know you as Ruth, even though you're Dr. Ruth. So, the main reason I wanted you on the show is because you have really amazing expertise and training and, just sort of time in, as it were, in the whole issue of mental illness. And I know that you were also very instrumental in helping a lot of students when we had the Marjorie Stoneman Douglas shooting. So it just seems like, with all this, with all that's going on, I know that the mental health side of our practice is really starting to grow, and the work that Audra does. And I'm just really excited to have you on because even with the kids that I'm marching at, we're seeing so many of them have mental health issues. It's like an epidemic. I mean, I know the substance use issue is an epidemic, but so it just seems like it just seems so much mental illness out there, and I don't know why that is, but we'll get into that. But I appreciate you taking some time to chat with us about that.
Thank you.
You're welcome. So I want you to, because you have really amazing training, and I want you to tell everybody just a little bit about your training and background, and then we'll get into the whole meat and potatoes of it.
All right. Well, let me start off. All my formal education is, of course, from England, from the United Kingdom. I have a bachelor's course in health and science and then psychology. I have a unique master's in psychotherapy and counseling. And then I have a master's of science in counseling psychology and then a PhD in psychotherapy. I also was a PhD here in education leadership. So there's a lot of that background, but my training...
Let me ask you before I'll let you get into that, but what is psychotherapy? What is that?
Psychotherapy, in England, we do it psychodynamic psychotherapy training. It's all based on the old school therapy of Freud and what we call the forefathers of therapy.
Okay.
So you're really talking about, I like to put it in simple terms, couch therapy, where you're really looking at how childhood plays into a role into current life, how the lifespan of somebody interacts with today's well-being, and you're not just focusing on the here and the now. That's the traditional model that I was taught in. And many people use the term loosely. So if you're just going to counseling, some people might say I'm having psychotherapy, but it's not actually psychotherapy, psychodynamic treatment. So it's a loosely used term. And there's very few actual people I know here in the USA that actually specialized in psychotherapy.
Right. So how long was the training that you did in England for?
I have 15 years.
Of just training?
Yeah, from the age of 18. In my academics, yeah,
that's a lot of
years.
That's a lot of time.
And that's a long time for psychologists here too. That's how long it takes some of them as well.
Wow.
Yeah.
So what brought you over to the US?
Well, I worked for the NHS, which is the National Health Service. I did all my internship clinical rotations with the NHS and then Her Majesty's prisons. And then after I left Her Majesty's prisons, I ended up working here as a psychological specialist for Broward Correctional Institution, which, yeah.
So you spent a lot of time in the prisons, which is interesting because when I was a young prosecutor, it didn't take me long to figure out that most of the people that were in our systems of justice were there because of either issues of substance use or mental illness. Not every single person, but a lot of them were there, and that's why they just kept going through the sort of revolving door of the courthouse because they just weren't getting help.
Yeah, that was my experience. Broward. Let me just start. Broward Correctional Institution was the maximum security prison for women. They closed down a couple of years ago actually, and they moved everyone to the main annex in Lowell. But it was the reception center where everyone sort of was sentenced and they arrived at BCI. We did their mental health assessment and we determined what level of care they required while in prison. And we would label them S1s to S3s. and an S3 would receive full psychiatric medical care based on their mental illness. We saw a great deal of patients who had substance abuse issues, as well as just pure mental illness, not really using substances, but had lived risky lifestyles because of their mental illness. And really, they weren't getting treatment in the community.
Right. Do you think they get treatment in prisons? Because I've had, or even just the local county jail. Because I've had one or two clients who ended up going to prison and said to me, and they had substance use issues, and they said they got better drugs in prison. And I'm just wondering if mental illness gets worse in prison too. I mean, are we when we making people come out worse than what they went in? I mean, how's that? What do you see? Or what did you see?
I have a different perspective on that. I had a few lifers on my caseload. So I had people that weren't paying a mortgage by doing time. Sorry, paying rent. They were paying their mortgage. They're there for life, literally. And after about 10 years of freaking out, adjusting, they calmed down and they really want to have counseling. And they enjoyed the counseling. There weren't that many on medication, the lifers. For those that were receiving shorter sentences, less than 10 years, the goal is to stabilize them and to get them to behave on the compound. Can I call it treatment? For that population, not really, not when you've got 130, nearly 200 patients on your caseload that you have to see every 30 days.
That's crazy. I've got one client now. I'm not going to mention his name. He's been in the press, who is actually in federal custody. And his is an unusual case because he had an absolute shyster. Actually, he had two shyster lawyers, one of whom ended up being a government witness against him. Believe it or not. It's quite interesting to learn that your lawyer should actually sell you up the river. But long and short of it is I've spent some time with him. I know his family. He's somebody I would consider a close personal friend. And I see what prison does, not just to the inmate, but it does to the family too. It's really, it does horrible things.
Sometimes prison can save some of these women, for the women I worked with anyway, save their lives. They're fleeing gang violence and being inside. I had an inmate actually that committed a crime to go back to prison because she had people who wanted to kill her. So she was safer in prison than she was what they call the free world. So I think for some people, prison is their safety net. And then once they become institutionalized, that becomes their life. That's all they know, is going back and forth to prison. And I remember I had an inmate, meth was her choice of drugs. Literally, she was released on a Friday, violated parole back on a Monday for drug use.
Unbelievable.
Yeah. Unbelievable. So sometimes it's a revolving door, especially for those with substance use.
All right, let's sort of get into the meat and potatoes, because one of the things that we talked about, was it yesterday or yeah, it was yesterday, right? And I said to you that one of the things I was seeing was, I know the days all seem to merge into each other, right? Was I was seeing, even the kids that we march for an act or we do some type of emergency guardianship for, the ones, first of all, whenever there's substance use, 99 times out of 100 there is a mental health issue. And sometimes, as a non-clinician, I can't tell you if it was the chicken or egg which came first. But one thing that is very constant, and I think this is perhaps a little bit of a controversial position, but I'm going to say it anyway, which is that there seems to be a lot of kids who maybe when they were younger, 8, 10 years old, maybe 12 years old, were prescribed some type of medication. Somebody said, oh, your kid's got ADD or ADHD, and they were prescribed a medication, and then things just started to progress. They went from the medication to to marijuana, and they went from marijuana to coke, then to heroin. I mean, I'm not saying it happens in every case, but I am telling you that in the cases where I do a Marchman Act, 9 times out of 10 there is some history of some type of medication that was given at a very young age when the brain is still forming, and it just seems like that is a constant. And I wondered, just from if you can give us some kind of clinical perspective on that and why you think that is, and am I seeing things that aren't there, or is it real?
I'm going to give it more from a research, because Here, I don't really do clinical work, so I do more research stuff or program development. So I'll give it more from a research perspective on what I found. And I've been working with the documentary writer actually regarding some of this, and you are spot on. Basically, what he's found in my research is that when you are prescribing medication, and some medications now are designed for 2 and 3 year olds, so that's really where we're going. It's pretty much out of control, some of those. When you are diagnosing, first and foremost, ADD, some practitioners will, in children as young as 5, parents want to know how to fix that. Rightly so. They want to help their child. They want to know how to help them stabilize.
Let me ask you a question, Ruth, not to interrupt you, but I just remember as being a kid in school. Now, my parents sent me to an all-boys private school in England. And if I didn't sit still, that was back in the days where you got a rap in the knuckles or it was bend over and get the cane. And I'm not advocating for that. I'm just saying, and even as a 52-year-old, adult, I sometimes have a tough time focusing on any one thing at any time. But just maybe tell us when somebody says, well, my child has ADD or ADHD, what is that from a clinical perspective? What is that?
Well, I think when you're trying to first and foremost, there's many ways to diagnose. So
what exactly is ADT? I know what the definition is, but what exactly is it?
Well, you're looking at traits of behavior. So you're looking at behaviors that the child is doing, unable to focus, isn't clear with their thoughts, can't sit still, engaging in destructive behaviors. And these are all subjective views. And what do I mean by that? That's what you're seeing. And how do you do a test on a 3 or 5 year old? How do you do an actual test? What tool can you use on a 3, 4, 5 year old to really decide if that child has a deficit disorder? There isn't really that test available. We do see it. And many psychologists, even psychologists I know, will use tools to conduct an actual test as the child is aging, say after the age of 8, to really make a more accurate diagnosis. And in the UK, just changing to there for a second, because this is an area I do know very well in the UK, we use neuropsychologists to actually make a diagnosis, which is not going to be subjective.
So what is that? What's the difference?
Well, because the neuropsychologist is looking at the development of the brain and how that's impacting, because we're saying that pretty much ADD is on the spectrum disorders. So what is a spectrum disorder? You're looking at autism, you're looking at that area. So we're saying it's a spectrum. We've made many changes on how flippantly it's diagnosed. We look at teachers. I don't think a teacher's qualified to tell anybody that their child has ADD. Then we look at pediatricians and a clinical psychologist. Yeah, they can do some testing tools, but if you want a true, accurate result, you would go to a neuropsychologist, which is what you have to do in the UK, to actually get an assessment for ADD, because we're very resistant to the drug therapy.
So I got a question, we have like this sort of pyramid for food, right? And they say, eat a little bit of this, a little bit of that, and then a bit more of this. And it turns out that if you look at the food pyramid, you actually need to turn it upside down, because what it was really designed for is for us to buy a bunch of food that is terribly unhealthy for us. But hey, it makes a bunch of farmers a ton of money, because that's just what makes the world go round, at least in this country. And I'm wondering if the whole idea of a spectrum is accurate. I don't know if it is or it isn't, but we're talking about it, and I just sort of crossed my mind. I'm like, is it really accurate, or is it some kind of something that has been created so we can sell a ton of medication?
I think that there are some elements where it is accurate, where there are true cases, but I think we have to tread carefully here, because we have to use more objective assessment and tools. So if, for example, I'm writing a program and I'm addressing those areas like ADD or so forth, I would expect that those clinicians that would work for me would use a real testing tool to make an accurate assessment or examination of the child. And that goes with things like simple things like depression. We have the Beck Depression Inventory. It's a tool. We use it because we can make an accurate diagnosis from that. We don't want to use the BDI on a 3-year-old child. You're not going to get the result.
BDI is what? BDI.
the Beck Depression Inventory. It's a testing tool that will help clinicians determine if someone's depressed. It's a more objective way than someone just saying, hey, you're sleeping well, you're eating well. It's a more objective, concrete determination if someone's got a depression or experiencing depression. We want the same tools with children with ADD. And I don't call it lazy. I don't want to say it's lazy parenting, but I think that we have to understand kids are kids. Boys are boisterous. Girls want to run around. People want to do cartwheels. They're just kids. And we're not here to just keep them quiet. They are children. And yes, there are those with a true disorder, but I think we need to be more mindful and more aware of what's going on. And the drug therapies, I mean, we are seeing a lot of consequence. I'll just give you an example of some of the consequences that we're even seeing in adults. Do you remember a couple of years ago, the guy that shot up the university library at FSU, I think it was, in Tallahassee?
I think so. There's been so many, and there's been so many shootings, and so many of them are attributable to sort of, mental health.
Yeah, well, his name was Moya. He shot up about 5 people at the library at the university in Tallahassee. He actually drove all the way, I think it was from Texas, to do it. He had been living in New Mexico, and he was having struggle sleeping. He was a lawyer. He even knows, he was in the class with Matt Gaetz, Congressman Matt Gaetz. So he had been successful at what he did. He became really tired, a little bit agitated, and he goes to see a psychologist in New Mexico. He was engaged to a physician, actually. And the psychologist in New Mexico decides that he has adult ADD and diagnoses him with amphetamines, a Ritalin-based medication.
So you told me yesterday that that's basically speed, legalized speed.
I'm going to go down to the drug dealer at the end of the road and get some speed. So I'm going to get some speed for my kid. For this guy, he was diagnosed. Now, in New Mexico, the licensing rules are very different. So, and we're actually seeing this start to happen now in Florida. There's a bill going through this year where psychologists can prescribe medication. Now, they have to do like 2 years of psychopharm training, but they will be able to prescribe medication in the state of Florida. Now, this psychologist, licensed psychologist in New Mexico, prescribed this guy, never had a history of childhood ADD, went through law school, was on top of his class, went on, got his JD, everything, the top of his class, was a leader, okay, young African-American guy, diagnosed ADD. What does he do? A month later, after being on the medication, shoots up the library. No history of aggression, no history of behavioral disorder, nothing. Grew up in a healthy environment, in a small town in Florida, was on the track team, was one of the top of his class in school. All of a sudden, he has ADD and he needs to go on medication. And then he shoots up the school. What we do know, well, the FDA have what they call a fact-finding system. There have been so many reports of aggression linked to ADD medications because it's amphetamine-based.
Yeah, but I always thought, see, my understanding of these medications, they're supposed to calm down. I mean, I have some friends of mine, and they have I think he's 15 or 16, and the kid is very animated, boisterous, and I hadn't seen him in a couple months. I said, "Oh, how's he doing?" And they said, "Oh, we put him on a medication. He seems fine now." And I'm like, "You're medicated, and why?" And the long and short of it was that the kid they felt like he was almost a little out of control. And I was a little bit shocked and surprised. And maybe it's because I see this every day in our practice, and so for the parents, they don't see it. But when I hear that, I was almost mortified, quite frankly.
Yeah.
Mortified. I mean, you're calming him down. Why? Is something wrong with him? Yeah, he's a passionate, boisterous kid, but he's a boy.
Mm-hmm. Yeah, we're seeing some of that, and I think that's why we've got to be mindful. And there are those very reserved psychologists that I know that are mindful that they don't want to overdiagnose or they don't want to diagnose, but you're seeing a lot of people that just willfully diagnose, whether it's psychiatrists, whether it's school psychologists, just making these diagnoses, where The well-trained psychologists I know are very cautious about doing that, and they want to wait. And they're like, bring your kid back when they're 8 or 9, and we can sit them down and we can do some real testing. Or here's a neuropsychologist I can recommend. And there are many out there. But I think that those that are in haste to medicate their children need to be aware of the downside. Now, the parents have choices. That's their free will. But I think they need to start researching more about what's involved with that medication. When you're seeing numerous people writing reports, and I can tell you, the documentary writer I work with, he testified in Congress in Washington against the FDA and their reporting system on medications for ADD.
So we're basically taking kids as young as 3, and we're putting them on a medication which is basically the equivalent of speed.
Yeah.
So, I mean, I've always been told, the brain is still forming until age 25. So we're going to put a kid who's 3 years old who has another 22 years of sort of brain development, and we're going to put him on speed, potentially for many, many years. I can't imagine that does anything good to the kid. I'm not a doctor, but I just, from a common sense point of view, that cannot be good. And I'm not saying there's probably never a time for medication, but how out of control can a 3-year-old be? And if there's something going on, maybe, maybe it's not just, because we seem to live in an environment, and my brother's a doctor, and he gets very frustrated with this because before he went to med school, he was a holistic medical practitioner. He says we're very quick, to give, someone comes in the ER, take 2 pills, call me in the morning. I mean, we don't seem to get to the root of something.
Yeah.
It's a little frightening.
It's definitely becoming a problem. I mean, when I even look at myself, I'm very cautious on what medications I even take. Even after a C-section, I was given Percocets and I still did take it, and I only took Motrin. So again, you have to decide what works for you. I mean, I'm all into free will, free choice, but I think
just make it informed. I'm not sure we're getting all the parents are getting they're getting all the information, all the evidence they need. And and the other thing is, look, I have a brother-in-law who's a doctor, and I know that he's in private practice as opposed to my brother who works in a hospital setting, and just from what I've seen, he's inundated like on a almost daily basis by the pharmaceutical reps coming in one after the other promoting their medications. And I'm just wondering, and I'm not initially blaming the doctors that are prescribing the medication. I'm just wondering, are we creating a whole sort of generation of doctors that are trained to just very quickly give a medication?
There was a cycle. It's funny because I was speaking to an MD about this. There was a cycle in training where it was just pain management. Ease the pain, because then you have satisfied patients, because they have this whole patient satisfaction, especially at hospitals. So ease the pain and everyone will feel better. Well, the problem with that is you become in the mentality of just writing prescriptions to ease the pain instead of treating possibly underlying issues that are going on, or giving them other options like physical therapy or so forth. So we became that thinking. They've changed it after the opioid crisis. The American Medical Association have become more aware of that, and a part of the training is to be very cautious on how they are prescribing medications that can cause addiction and over-prescribing.
Okay, so is there from a clinical perspective, is there a link between the kids that are giving these medications and addiction?
I think the current research is showing that there is. The FDA have a pack of information that already shows it is, that actually these drugs can lead to aggression. So, again, those with serious, you can't eliminate the fact that some children do have ADD, ADHD, but for those that possibly we should be cautious in diagnosing because they're young to learn what's going on with them, and maybe we need to investigate other areas like home environment and so forth before a determination like that should be made, or a prescription that is amphetamine should be prescribed. I think we should be more cautious, and we're not. We're becoming so whatever with it. Oh, you got ADD, so does mine. What drug do you take? I mean, it's quite sad, really.
Right, it's frightening. So let's bring things a little more current, because I know that you live in, are you in Parkland, right? Are you in Park?
No, now I'm in Aventura, but I was in Parkland.
Right.
Yeah, I was in Parkland.
So what really caught my attention about what you were doing was the fact that after the shooting took place at Marjory Stoneman Douglas, you worked really closely to provide services with other clinicians to some of the kids that were having issues there, right?
Right. My company at the time was providing, the clinicians that worked for me were providing services. So I had been approached by a number of parents to ask if their kids could receive treatment from therapists that were skilled in trauma. And that's what we did. We had skilled therapists, those that had been certified in some kind of trauma therapy, skill-based trauma therapy, meet with these children through telehealth. A couple of the therapists actually were not even in South Florida. They lived in Orlando or Sarasota and were visiting the clients online via the telehealth platform.
So how many clinicians did you get as part of the team?
13 clients that were being seen by therapists. One actual client, her mother was also being seen by the therapist. She was even struggling to cope with what her daughter had seen. And that particular girl couldn't even leave the house for the first week. She was in the classroom when saw 3 of her classmates die.
And how old was she?
14.
Wow, that's pretty. Well, I mean, obviously, we both know Max Schachter, who lost his son.
Yeah.
In the thing. So where does this all lead us? Because I mean, these sort of shootings, these mass shootings by really children. I mean, I know that he's been described as a monster, this young man, and maybe he is, but at the end of the day, he's a kid. So, I mean, and maybe we don't need to talk about him specifically, but where does this all go? I mean, are we looking at more of these things type of actions happening? I mean, how do we prevent another something else like this? I mean, where were the mistakes? Maybe where are mistakes being made, or where can we prevent them from being made? Because he didn't just wake up one day and say, I'm bored today, I think I'm going to go shoot up the high school. I mean, this was something that he obviously was premeditated. He thought about it. He planned it.
Well, I'm going to use something that Andrew Pollock told me when we were talking. And
so, just so everybody knows, Andrew was also a parent that lost a child there. Great guy, too.
And Andrew explained to me that 50% is owned by the killer. I mean, no doubt he's responsible. But it took a village to raise a killer. And I thought that was so powerful. When he told me that, he literally said, Ruth, it took a village to raise a killer. That's what it took. And I looked at him and I said, wow, that's a powerful statement.
Very, very profound from a father who lost a child.
Right. I mean, and he works tirelessly to get some answers for the loss of his daughter, and who can blame him? But what he's really saying by that is you had this boy who obviously had many issues. Who knows what his issues are? But he had many. Some of them are documented, some of them not. He had a history of getting crisis call out from the agency that was serving him. Police went to the home. Threat assessments were done. From school to the mental health to the police, he slipped through the cracks. Every provision was there, but he slipped through the cracks. So he didn't actually slip through the cracks. It's just a case that no one did maybe what they were meant to do. So when we look at mental health providers, what is a service and how they work, that's where people, I think, struggle. They struggle with a service. So for example, I had a private company. That private company takes people in and they pay out of pocket or they pay through insurance. Then there's Medicaid or grant funding agencies, which is, for example, like the killer received. He received grant funding Medicaid services. Now, just because it's Medicaid doesn't mean it shouldn't be competent.
Do we know if he was medicated? In other words, do we know if there's a medication component here?
Yeah, he was on. He was diagnosed ADD.
Okay.
On an amphetamine-based medication. Yes.
Okay. Just wanted to, as I was sitting there, I'm like, okay.
Yeah. Based on reports, he was on that, and then he was placed on a mood disorder medication as well. So we see a lot of trends in some of his behaviors. I mean, if you're up all night because you're on amphetamines and you're not doing anything during the day, and then, you're calling, I guess, a crisis, and then no one's actually doing a Baker Act when you call a crisis, even though you're presenting certain behaviors. And it could have been a missed opportunity. I think that's what Andrew Pollock is saying. It was a missed opportunity to actually stop this.
Is anything getting done? Do you think anything is getting done? Because I've been reading about what Andrew's doing. I also read about Max, and it seems like just from what's been put out there that they're, it's almost like they're banging their head against a brick wall, hoping that at some point they'll make a hole. I mean, it seems like they're fighting the good fight, but I don't see, I don't see a lot of positive response from the powers that be, government and all that other stuff. I mean, maybe the most positive thing was the fact that they suspended the sheriff, but I don't know if that changes anything, on the fact that we're holding him accountable because his guys didn't run in there and try and stop this kid.
It's really interesting. Maybe you'll appreciate this, and those in mental health will definitely appreciate this. When someone says mental health, what do they mean? What does that mean? How do services in mental health work? Do we even know? When you say Baker Act, to an average person, they're like, yeah, you should have Baker Acted him. But you can't just Baker Act everyone. There's certain requirements you have to meet to Baker Act someone. Right? Those are laws, policies that are set down by the legislator. So we have all these terms, and you say mental health, and I see it all the time, social media. Oh, he was getting mental health. But what does that mean? There is a difference between mental health treatment provided by a clinician versus mental health services. What is mental health services? You first have to ask yourself that. Well, that's someone going around saying, are you going to kill yourself? No. Okay, good. You're going to kill anyone else? No. Good. You're going to hurt yourself? No. Good. All right. You're hearing things, seeing things? No. Good. All right. Bye. See you in 30 days. That essentially is mental health services. Is that what he was getting? Or was he sitting down with a clinician? From my understanding, I don't believe he once saw the clinician. He did see someone come to the home. Was that the clinician, or was that just a caseworker? So there is a big difference between someone receiving mental health treatment versus services. And I think that's what people don't understand. And that's where I think there needs to be drastic change. There needs to be clarity for the general public so they understand what they're meant to receive, and hold people's feet to the fire so they actually do get the services or treatment they're meant to.
But brings up an interesting topic as we talk about the Baker Act, so maybe we'll sort of transition into that a little bit, because I want to pick your brains on that, because you obviously know about it a lot. I only see it from sort of the non-clinician side of things, but we get a lot of kids who are
I see it more from like the legislative point of view, the delegation part of it. That's I really don't see it from, because in England I use the section 24,
which is the English equivalent of a Baker Act, but we get a lot of kids who sometimes they've been Baker Acted, and that's when we might step in with a March Parental guardianship, or they're in treatment and there's a Baker Act initiated.
Right.
And from what I've seen, the receiving facilities are they're not particularly nice. You could probably go more nuts in there than you could on the outside. And I'm not saying we shouldn't do something with somebody who yells, I'm going to hurt somebody or I'm going to hurt myself. But somebody who's threatening to hurt themselves, I just don't know if we're supposed to be, quote, stabilizing them within 72 hours. I don't know if we're able to do that, or if it's just sort of putting a Band-Aid on a more serious issue. So, I mean, maybe we can talk about that.
I'm going to give you an example. A friend of mine who's an attorney actually in Broward County, who I stopped to see him after I was testifying as a guardian ad litem. I was like, let me go in and say hello and see how he's doing. He's a family attorney, but a friend of his had called him up and said, my wife, or his wife's sister actually, had been Baker-acted and placed in a hospital in Broward. And she already was what we called in the prison a jumper. So for example, she'd jump off a building or jump off a bridge or jump off numerous stairs or flights to hurt herself. She was threatening to hurt herself. After 72 hours, they discharged her. She killed herself 3 hours later. Yeah. So can we stabilize them? That's an interesting question. I think there are programs where someone's Baker-acted and then, like in some of your clients' cases, they're Baker-acted discharged to a facility. But generally, most people are discharged back into the community. And then they're followed up 24 hours later or 48 hours.
If you can
later.
find them.
Correct. Not everyone's going to be going to a facility straight after a Baker Act and then be in a position to know that there's even attorneys available to help them, or their families don't even know that there are attorneys that can help them with Management Act.
Yeah, I will tell you this. I was actually up at the Sober Homes Task Force this past Wednesday because there was a proposed change to the Management Act, and they asked me to come up and talk to them about the legislation. I will tell you that one of the big things that the task force has not only brought to light, but it seems to be taking action on, is the whole idea of services after the fact. So, one of the big issues that we're having, I think it's sort of a nationwide issue, but definitely here in Palm Beach County, was this whole idea of the revolving door at the emergency room. Someone would overdose, they'd get Narcan, brought in, they'd get stabilized, and whoosh, they'd be right back out. And sometimes they were overdosing in the parking lot and come right back in again. So I think there's been a real push to have services available. But I can tell you, I remember when my father was sick. So my dad passed away 2 years ago, but for the 2 years before that, and he was sick, and my mother and I were either calling 911 or just taking him to the ER, ourselves. There were times where here's my father who's having all kinds of issues. We physically couldn't get into the ER because there were people in the waiting room and also in the ER who were there for overdose. I mean, they'd have them lined up in the hallway. It was unbelievable.
Wow. Yeah. I think we have to be more I really think people need to be more informed. And we talk about education, and again, another loosely used term for mental health and substance abuse. We must educate people. Go do more than that, actually. Go tell people where they can get services. This is how you get the help you need. And what I mean by services, whether it's your help, whether it's a facilities, grading center, whatever it might be, the real information where people can say, oh, I need to make an informed judgment. I'm going to spend all this money. Let me do it right, so I don't keep repeating it every 3 years. And I think that's where the education has to be. It has to be more about someone making an informed decision. And
the other thing is, look, and I've talked to our drug czar here in Palm Beach County, John Hewlett, who used to work for Governor Christie, and he's experienced it firsthand because he has a daughter who's dealing with issues of substance use, and I know he's really working hard to try and put all the missing pieces together. But it just seems like if you have insurance or you have some financial resources, you're better off than if you don't. And if you don't, it's difficult. It's really difficult. If you don't have insurance or money, it's very difficult to get access to services.
Yeah. And then, we think of those that in mental health don't know where to go to get access to services. Real services. Again, going back to what is treatment, what is services. Are you looking for treatment or are you looking for services? Services is pretty much what you'll get if you've been, I know you're a juvenile and you've been arrested by BSO, and you'll get someone do a home visit. You'll get some services. Treatment is when you'll sit down with a clinician in their office and they're really monitoring you, and there's a multidisciplinary team that is working with you to get you back to where you need to be and stabilizing you. And we have a friend who, basically it's taken him a long time to find the service that works for his son. And we have to be mindful of the stress that has on a family member watching your child suffer, and no one's giving you a right answer. No one's giving you any help, and you feel like you're wasting your time. And then you become dissatisfied with the mental health industry and resistant and annoyed. And it takes a long time to find the right care provider to give you the answers.
Look, there's a lot of chefs in the kitchen. There's a lot of people with different opinions. And the other thing I learned is that, there's no one size fits all, right? There's no one medication that works. And if it does work, it doesn't always work. It doesn't continue to work, or it may not continue to work. And so, look, it's not an easy nut to crack, as we say. So
right, and there's there's a testing now that you can even do to find out how you'll respond to certain medications as well.
Wow.
There's so many tools out there.
So before we wrap up, where does this all leave us? Like, what's the future look like? With substance use and mental health issues, and sounds like I'm going to be busy for a couple more years. That's what it sounds like.
I think
I already work 25 hours a day and 8 days a week. How much? You know what I mean?
Well, this is it. I'm off to Tallahassee on 11th, 12th, and 13th to actually discuss this with the delegation from Broward Days, and sit down with the governor and sit down with the lieutenant governor and have a real conversation about mental health and how it's impacting not just Broward County, but everywhere in Florida. I would think
from a financial perspective, it's got to be costing us an absolute fortune when we're not dealing with this issue. I mean, if the bean counters in Tallahassee could get that through their heads, maybe it would register.
I've got to tell you, when I met with the governor before, and we spoke about mental health, and he actually is allocating more funds. When we actually lost funds in the last session, after Marjorie Stoneman Douglas, I don't know if you're aware, after that happened, they took money from substance abuse, okay, and they cut all the funding, like $20 million gone, and put that into school safety. So this time around, I think the governor has really looked at, we need to focus on mental health. But again, for a lot of the legislators, what's the difference between mental health versus mental health services? Now, some of your viewers might disagree with this, but I have to congratulate Representative Grom. I was on a panel in November in Orlando, and we were talking about innovations in mental health. And he said, okay, Ruth, he goes, I'm just going to throw it out there. We could put $1 trillion into mental health, and the outcome's going to be the same. And I said, correct. If you keep allowing people to not produce good outcomes. So a simple survey of how you doing, are you still in recovery, or are you on your medication, that doesn't work. What we need is concrete science, concrete research to show that your outcomes are right and you are compliant. And that should be what gets you funding, not simply a survey. And he was like, well, maybe that's where we need to go. Because now you're basing it on better information. Because he was honest. He's like, you could pour all this money in, it's like an endless pit. Where does it stop? Where is the outcome? Nothing changes.
I love it. All right, so what are you doing with yourself these days? You're in Aventura. You must love the traffic down there this time of year. I mean, if that doesn't let me tell you something, if that doesn't get your medication, good luck to you. It's a lunatic asylum down there. It's like bumper cars.
Well, right now I'm working with an agency in Miami-Dade implementing telemental health and policies and procedures for compliance. But my passion is about getting people to be more compliant with their own policies and procedures and providing better services so their clients benefit from them in the long run, improving organizational workflows so you actually have a real product for your clients to benefit from. Because this has become all about how quickly people can get services and the right services. So I like those good programs, and I like to work with the good programs to get them where they need to be. So that's what I do. It's more behind the scenes.
Okay, so when people are watching the show, maybe they catch it on a rerun, how do they get a hold of you? Are you taking private clients?
Yes, always.
All right, so let's give out your information. Let's go.
Absolutely. I always take private care, and it depends if I could, but I'll be fair. If I can't help them, I always refer to people that can.
I love
because
it.
you gotta know your limits. I'm don't do clinical, so don't come to me for clinical work. If you want to program policies, procedures, or workflow, then yeah, I'm the girl. But if you're wanting clinical, not me. Programs that work and based on scientific outcomes and evidence-based practices, yeah, they're available and that I will help with. But I don't do therapy. All of that, I don't do therapy.
So how does somebody get a hold of you then?
Well, they can email me at ruth@plum, PLUMTHS.com. So ruth@plumths.com.
Okay, is that your website, plumths.com?
Yes, that is. They can email me there and look at the website, check it out.
All right. So let me just give my little spiel, but don't go anywhere yet because I'm not done with you. So guys, before I give out information about how to get a hold of us, one of the things that we started here at Drug and Alcohol Attorneys is question of the week. So if you have any questions or issues that you want me to talk about, so we're inviting people to submit questions. Go to the Drug and Alcohol Attorneys Facebook page where you should be watching this show or you watch a rerun. And if you've got any questions, post them. I'll answer them in a video. But meanwhile, you can follow us on our Drug and Alcohol Attorneys Facebook page. There's my personal page, which is Mark G. Astor. You can follow us on YouTube and Instagram and Twitter. And actually, you can also see this show and reruns of the other shows that we've done on our drugandalcoholattorneys.com Facebook page. And if you want to get notifications, go to YouTube and subscribe to our channel and hit the notification button, and then you'll hear about our new shows. So, and also, if for some reason you want to get a hold of me or you just want to get a hold of Dr. Ruth and you didn't catch that information, you can call us at 561-419-6095, or you can email me, Mark, with a K, M-A-R-K, at drugandalcoholattorneys.com. Ruth, I'm really glad that you came on. This was really interesting stuff. This should definitely get people talking and posting comments and questions, and I really appreciate you coming on. So,
thank you.
Thank you for coming on.